for sake of starting out, I figure out why are we going through all this effort to talk about breast cancer? It's a big deal, but why? Why am I not talking about dry skin? I mean, more people probably have dry skin than breast cancer, but it's important. Why is it important that we're talking about breast cancer? It's common. It affects a lot of women. I think the latest statistics say somewhere between 1 in 7 or 1 in 10 women will get breast cancer in their lifetime. It's important because it affects people that are of all ages. It's not picky. It's something that younger women have to think about. It's women at all ages and it's scary, right? It's when we talk about cancer, it's a scary word. Dry skin doesn't have that same fear factor, perhaps. It's something that it can be life-threatening, right? That's why we're here to spending an evening at a lecture talking about breast cancer, and so there's a few different things I want to try to maybe explain. I think the title of the talk is, how an oncologist thinks about breast cancer. And so I want to try to, give some perspective there. I think when we think about cancer, I think the first thing that goes through our heads is, people on chemotherapy or people having some kind of surgery or, losing their hair. That's the first thing that I think goes through our minds. Or we see, children without any hair, bald in the hospital, in a hospital gown. We have that sort of picture in our mind when we hear the word, cancer. And I want to try to, probably get away from that being the first thing we think of when we hear the word cancer. I think with breast cancer, we have a screening test, right? We have a way to catch it early, and that is mammograms, right? We have a way to catch things early, and so the first thing we think about that's important is early detection, and it goes without saying, mammograms. If you're going to see your doctor for your annual checkup, that should be on their list of things to schedule or arrange for you. That's easy, right? Well, I shouldn't say easy, right? It's easy for a man to say that going for a mammogram is easy. They're uncomfortable. They hurt, but they're quick. You do it once a year. Some studies are saying maybe once every 2 years, but if you do it, it's done, it's over with, and you pretty much know that you're in the clear, and you have to do it a few times. You have to do it over and over again, and that's important. That's probably the most important thing I might talk about all day is early detection and getting mammograms. Right now, the current guidelines say, somewhere between age 40 and age 50, starting and getting a mammogram every 2 years. I think some doctors' organizations would think about maybe every year rather than every 2 years, but what's more important is getting a larger percentage of our population screened. If only 30 or 40% of people are getting mammograms when they're supposed to, that's not really good enough, whether we say the rules are every year or every 2 years. If only 30% are going to follow the rules anyway, then the other 70% are left to chance. And that's not really good enough as far as a population and how we take care of our neighbors, our friends, our community. 30% just isn't enough. But honestly, that's probably the actual numbers of women who are actually getting mammograms on time and regularly. And so that's not good enough. That's not high tech. It's not the latest and greatest drug for breast cancer. That's mammograms that have been around for, I don't know how many, 30, 40, 50 years. And that's probably the most life-saving thing that I'm going to talk about all day. But if I'm going to pretend like there's a woman sitting here, and I'm going to use her as an example. But if, if, let's say a woman, let's say 45 years old, healthy, goes to her doctor for her annual checkup, gets her cholesterol checked, gets her blood pressure checked and checked, and the doctor says, okay, go and get your mammogram. It's about time. You're not a kid anymore. You're not a teenager. You're old enough to get your mammogram, and go. And she goes to get her mammogram, and then she shows up at the mammogram place, and they do the mammogram, and it's uncomfortable, and it's what you think it's going to be, and they say, oh, we found something. There's something there that needs to be examined, or looked into further, and it may be something that you could feel. It may be something that we can't feel with our own hands, but it's there, and so, what would the next step be? All right, a biopsy. And what is that? A biopsy is and usually it's going to be done with some kind of pictures helping, but it's usually with an ultrasound on the breast, taking pictures of the breast at the same time and using a needle to go through the skin right into the breast and get right to the spot, because you can see it on the pictures, and you use a needle, get there, get a sample, take the needle out, and then that stuff that's collected by the needle gets sent to the lab, and then somebody looks at it under the microscope and says, oh, is it a cyst, or is it just fibrocystic changes, or is it benign stuff, or is it just fatty tissue, or is it actually a cancer? And that's the first step. And let's say the same woman, she's 45 years old, she gets this result from the doctor, and it says, oh, the biopsy showed cancer. Then what's the next step going to be? Next step is going to be trying to get it out, right? Cut it out, get it out. We don't want it there. And so you're going to get to see a surgeon. And the surgeon is going to say, it's small, hopefully, it's small. We caught it early because we got our mammogram on time, and we can cut it out. It should be easy. It's small. And we'll also, when we do a surgery, we'll take an extra step, and we'll actually sample some lymph nodes from under the arm. That's the way the body's wired, that we have lymphatic channels in our body. We have lymph nodes all over our body, in our neck, under our arms, in our chest, in our belly, in our groin area. We have lymph nodes everywhere. They're part of our immune system, but they're all sort of linked with channels, just like arteries and veins. They're all connected, and it's a way that cancer can spread. And so, and that's the other reason. I should have taken a step back. It's the other reason why cancer is so scary and so important, is because it can spread. It can be something that's more than just a lump in the breast. If it was just a lump in the breast, we wouldn't be so worried about it. We would just cut it out and close our eyes and never think about it again. But because the cancer has a potential to spread, it makes it more concerning, and it's something that can become more life-threatening, and that's why we're here talking about it. But we're hoping to catch it early, treat it, get rid of it, and move on. But back to our example, we're talking about lymph nodes under the arm. That's the first place that breast cancer would usually spread to, because that's the way fluid is drained out of the breast, and these lymph nodes are all linked and through little very tiny little channels, and almost like veins that are carrying blood, but instead of carrying blood, these lymphatic channels are carrying fluid from the breast tissue to the lymph nodes under the arm. And so at the same time as a surgery, at the same time as removing a lump from the breast, we would usually use a dye in the breast tissue, see where that dye goes, and track it to which are the first few lymph nodes in the armpit area or axilla area, and remove those lymph nodes and see if they have any cancer in it. And then the same thing, the lump from the breast, the lymph nodes from the armpit area, all those would be removed and sent to the lab and studied under the microscope, just like the initial biopsy sample. And then we would start talking about a stage. After we do the surgery, we'd be talking about a stage. And we would use a lot of different things to determine what that stage is. Staging of breast cancer just got a lot more complicated in the last year or two. It used to be just based on size. Our old school system for staging of breast cancer used to be just really based on size and whether any lymph nodes were involved. And so a stage 1 breast cancer would really be something that would be smaller than 2 centimeters. We would only really ever know until we cut it out. When we first find a lump in the breast on the mammograms, it's not the easiest to tell how big it is. We really would have to wait till we cut it out to really know the exact size. Even with MRIs and PET scans and mammograms and all these tests, it's not the easiest to know exactly where a cancer ends and begins. We usually have to rely on actually cutting it out and measuring it under the microscope to know the actual size of it. And so when we do that, we get a more accurate stage. But the old-fashioned staging system used to be just based on size and where it is in the body. So a stage 1 breast cancer would be a lump in the breast that's under 2 centimeters or less. And a stage 2 breast cancer would be a similar sized tumor, but maybe spread to 1 lymph node. A stage 3 breast cancer would be perhaps a larger tumor and also spread to a couple lymph nodes. And a breast cancer anywhere else, if it had spread anywhere else in the body that we could find on a CAT scan or PET scan or any other thing, in a bone or liver, any one spot anywhere else in the body would make it a stage 4 breast cancer. But that's quickly the old-fashioned nuts and bolts way to stage breast cancer. Now, in the last year or two, it's changed quite a bit in that we're looking at more than just the size and number of lymph nodes that could have had cancer in it. And so now we're looking at whether the cancer had certain markers when we study it in the lab and test it under the microscope. We're looking at the estrogen markers, progesterone markers, HER2 markers, and these markers tell us something more about the biology of the cancer and what's making it grow and how aggressive it is and what perhaps the chances of it spreading to other parts of the body, even if we can't see it right now. And that has something to do. We also look at something else called grade. Grading of breast cancer is something the pathologists do when they're looking at it under the microscope, where they're looking at how many cells are dividing actively when they're looking at the cells under the microscope, and they're giving it a grade of 1, 2, or 3. And higher the number, higher the grade, the more aggressive the cancer looks like under the microscope. It's somewhat subjective, but there's some guidelines for the pathologist to use to give it that grade. And now we're using that grade also in incorporating it into the staging. So a smaller cancer, even if it was small, but it was under the microscope, looked like a grade 3, higher grade cancer, could be considered a little bit higher stage than a larger tumor that was considered low grade. And so that's another variable that's in the staging system now. And so grade, estrogen marker, progesterone markers, HER2 markers are all other things that we look at. Estrogen and progesterone are hormones that are natural in the female body, and they're expected to be there. But for most breast cancers, probably 90% of breast cancers, the cancer cells like estrogen. It's not because there's too much estrogen in the female body, but it's there. And the cancer cells are using that to grow. And in general, 90% of breast cancers have those markers, meaning that's estrogen helping the cancer grow. And that's not necessarily a bad thing. That's actually, usually those cancers are friendlier type cancers. They're slower growing usually, and they're easier to find early, and they usually don't require as much treatment. Usually we can do less with those cancers and still get very good outcomes. The HER2 markers, that's the third marker I mentioned. The HER2 marker is one that tends to, when we find that in the breast cancer cells, it tends to mean a higher grade or a more aggressive type cancer. Usually grows quicker. It's something that popped up relatively quickly, whereas the estrogen positive type breast cancers, those tend to grow more slowly. Those are the kinds that we tend to see, sometimes we see a little tiny shadow on a mammogram, but we're not sure if it's anything important. And next year, it looks maybe a little bit bigger over a year, and then we say, oh, maybe we should biopsy it. But it usually sometimes didn't change that much over a year. And we biopsy it and find out what it is. The HER2 positive type breast cancers, more aggressive type breast cancers, or breast cancers that don't have the estrogen marker on it or progesterone markers on it, those tend to be more aggressive and can sometimes pop up in just a matter of a year or two, from going from a normal mammogram to all of a sudden finding something. Or sometimes women have even had a mammogram 6 months ago, and sometimes we still find a new breast cancer pop up quickly. And that's kind of scary, but it can happen. And that's still, again, that's only a minority of the breast cancer we see, maybe 10% or less. But all those markers are things we study on the biopsy sample, and sometimes on the sample we get when we remove the lump altogether. And we use all of that information to try and decide how aggressive we need to be with treatment after surgery. And so for breast cancer, for any type of cancer, when we're thinking about the cancer, we think about what's the definitive treatment. What's the main treatment we're going to use to do it? And for most cancers, we're really talking about surgery, removing the lump, getting it out of there, and then going forward. And so one of the biggest things that we think about in breast cancer is after surgery. Again, we've got our lady, our fictional character, who went for her mammogram, who went for her biopsy, who then went for her lumpectomy, or removed the lump, and sentinel and any lymph nodes in the arm and removed them. And for sake of discussion today, let's say the lump was an inch, 2.5 centimeters or so, an inch in size. Let's say that they took out 4 lymph nodes from her arm, under her arm, and one of them showed cancer in it. The other 3 were benign, were clean, no cancer in it. And so now she's had her surgery, she's healed from the surgery, and now she's going to get sent to see a doctor like myself, a medical oncologist. And we're calling this, let's say the cancer was, let's say, positive for estrogen, like most cancers are, positive for progesterone, like most cancers are, and negative for the bad marker, didn't have the bad HER2 marker on it, and now she's coming to see me. And so the cancer's been removed, it's not there, there's not any, let's say we've done CAT scans and PET scans or whatnot, and we don't see anything anywhere else, right? Is she cancer-free? Maybe. The answer is maybe, all right? And so this is where my job gets kind of interesting. I've got a young woman who's otherwise healthy. She had found a lump in her breast, it's gone, it's been removed. She had lymph nodes from her arm taken out. She looks perfectly fine. And there's no cancer in her body that we can measure. But do we know whether she's cancer-free or not? That's the reason why we're sitting here even talking about breast cancer, is because there's a chance. There's a chance that there's some cancer cells somewhere in her body that we can't see, microscopic, to the point where PET scans, CAT scans, MRIs, whatever scan out there isn't going to pick it up. The truth is all the medical tests we have in our day and age right now are not 100% guarantee that anyone's cancer-free. Unfortunately, that's the ultimate unfortunate truth, is that we don't have a way for sure to say that. We have all these great tests, but they have to show things that are big enough for doctors to be able to see with our own eyes on a computer screen. And so when I look at that 45-year-old woman with all those things I said, I sit here and say, gosh, it's a 1-inch tumor. There's probably 1 million cancer cells in that tumor. It should spread to a lymph node. It's there. It didn't seem to spread anywhere else, nowhere that we can see. What's the chance that there's a cancer cell somewhere else in her body that's going to show up later, that's going to be there 5 years from now, or 2 years from now, or some point in the future, it's going to be there. And we don't want to see that, right? We don't want to ever have that happen, right? So I'm looking at a woman that's completely, as far as I can tell, she looks healthy. She doesn't look like she's got any cancer anywhere. But I've got to decide what else should we do to try and cure her, right? There's a chance that the surgeon got it all, right? There's a chance that the surgeon removed it, it's out, it's gone. And so again, this is where things get interesting for me. That's when a woman usually would come and see me in the office. And so, I'll make sure it's not paper. But there's really 4. I don't know if this is really. Maybe I'll bring it closer. Ugh. But the way I think about it is like, I'd hate to say it like this, but I think of it like a casino. This is like gambling. This is like trying to cheat the casino. All right? I'm looking at odds of what happens if this bar, it's like a bar graph. All right? If I'm looking at 100 people that all, this bar represents, let's say, 100 women like this one. And there's 4 possible outcomes, right? There's one where, let's say, the odd count, that 4 possible outcomes for breast cancer for really the rest of her life. One is that she's cured, right? That the surgeon cured her, and there's nothing else that even needs to be done, right? So if I had to guess, 45 years old, no other medical problems, a lump is about 1 inch in size, 1 lymph node there. I'm guessing that her chances of being completely cancer-free and cured because she had her surgery, probably about 60 or maybe 60%. And so, let's see if I have a different color. So 60% is that she's cured already, and that she doesn't really need my help. All right? Probably so the other things that we think of that we can do to improve those odds, right? 60% at age 45 sounds terrible, right? 40% chance of dying sounds awful, right? Oncologists are very morbid about thinking like this, right? I mean, we're talking about breast cancer because we don't want people to die from breast cancer. We want people to be cured. And so we want to tip those odds in your favor, all right? We want people to live another 45 years after that and not get breast cancer showing up anywhere else in their body. So if the surgeon has a 60% chance of curing somebody, what else do? We think about chemotherapy. Even though the person doesn't have any cancer that we can see in their body right now. It sounds crazy, right? Why would you do chemotherapy? There's nothing anywhere. But the truth is, if we give all of these women chemotherapy, 100 women, let's say 100 women, 60 were cured already, right? But we don't know. This one woman is in front of me right now. I don't know what's going to happen to her 10 or 20 years from now. I know what happens to 100 people like her, what the odds are. So if I give this woman 3 to 4 months of chemotherapy, then her odds of getting cured go up by about 10, 15%. So that gets, so you say 60. Now, again, I'm trying to cheat the casino here, and I'm trying to improve her odds. I'm trying to get to 70, let's say 75 with chemo. Now, if I give the other treatments we have for breast cancer, and I'm not getting into specifics about drugs or which drugs we're talking about using for chemotherapy, but the other main thing that we do for breast cancer, or a couple other things we do for breast cancer, one is radiation treatment. We'll give, for a woman who had a lumpectomy, we'll give radiation treatment to just the breast, usually the breast and maybe the armpit area, and try and kill any cancer cells that are hiding anywhere in that area that are too small for us to see or feel on exam. And so radiation treatment would probably add another 5 or 10%, right? So we'd improve our odds by giving radiation to that woman. So another, say, 85%. And notice that looks like I got tangled up here. But, and so 85% sounds better than 60%. The other thing that we would think about doing with treatment, with a young woman who's healthy like that, is giving her hormonal therapy. Her cancer was estrogen positive. It was driven by estrogen. Again, not because her body was making too much estrogen, but because the cancer cells, whatever caused them to develop, they were looking for estrogen. Estrogen was helping it grow. So in a woman like that, she's still premenopausal. She hasn't gone through menopause. She's still having regular cycles and whatnot. And so we would give her hormonal therapy, which is a pill medicine. You know, after she's done with radiation, after she's done with chemotherapy for 3 or 4 months, then we would think about hormonal therapies, which is a pill medicine once a day. Some of them, there's a whole host of a few different brand names, but it's usually 1 pill a day. And it's blocking estrogen in the body 2 ways. One is either just stopping the body from making as much estrogen, or blocking it, actually blocking cells from getting estrogen. Actually like sitting on the outside of cells and stopping estrogen from getting there and stimulating those cells. So the premise is that we're trying to stop this from happening in any cancer cells that could be hiding somewhere else. And so that hormonal therapy probably does just as much as the chemotherapy, probably another 15% or so. So the goal is to get as close to 100% as possible, and tip the odds in this woman's favor. And surgery is the main thing that is the main definitive treatment. But we don't know for sure that person is cured. The larger the tumor is, the number of things that go into this equation is the size of the tumor, how many lymph nodes were involved. The larger the tumor is, the higher risk of it showing up somewhere else. The more lymph nodes under the arm that we found at the time of surgery, the higher risk there is of it showing up somewhere else. If it was a higher grade tumor when we looked at it under the microscope, that's more concerning for risk. All those things make me wonder. And so this is kind of an example, but for anyone else. But, excuse me. And so again, we're trying to tip the odds in this woman's favor and trying to get her as close to 100%. Unfortunately, we don't always get to 100%. In spite of all the things that we do, there can still be a small % chance that the cancer can come back. And we'll talk about what we do in that situation. But the other thing we think about is not every woman's situation is the same. I can draw this bar graph a lot of different ways. I'll give you a different example. If I draw a line here, and now instead of, let's say she's 75 years old, and she's got heart problems, she's got lung problems, she's on oxygen to help her breathe, and very different situation than the first patient. And we find, let's say, the same type of cancer. Everything about the cancer is exactly the same. It's still about 1 inch in size. It was estrogen positive. It was one lymph node out of 4 showed cancer in it. Now the bar graph is going to be very different because this woman, if she's, pretty frail and not very healthy, this is how oncologists think. We're pretty morbid. We think about what's her chances of dying from something else other than cancer. And we would think about, okay, instead of starting from that end of the graph, and think about what the chances of her dying from something else in the next 10 years besides breast cancer. And so in that situation, we'd be talking about, probably a 30% chance of something else happening other than breast cancer. Unfortunately, in my office, if a patient I'm treating for breast cancer dies of something else, I consider that a win because they didn't die of breast cancer. I kept them alive long enough to not have to die. That sounds terrible, I know, but that's how I think because we have, unfortunately, taking a step back and from this example, unfortunately, we do have way too many women who are diagnosed too late, who didn't get their mammograms and are showing up with a a grapefruit-sized lump in their breast and lymph nodes that are positive that you can feel. I mean, they feel like golf balls under the arm, and even showing up with cancer already spread to the bones, and that's a completely different situation. We're not talking about a surgery, just a small surgery on the breast fixing their issues. That's a whole different ballgame, and we'll talk more about that later. But in these kind of bar graph examples, we're talking about four possible outcomes, right? One is being cured with the surgery, whether it's in either woman. It's a localized issue. It's just in the breast. It's just under the arm. We can cut it out and then go from there. And whether they're 45 years old or whether they're 85 years old or what, we figure out these odds. But there's four possible outcomes that I'm trying to figure out how to tip the odds in my favor. One is they're cured by surgery. The second is that something else I did, either giving radiation treatment, either giving hormonal therapy or chemotherapy, cured them. That's the second possible outcome, that some other intervention after surgery actually fixed it, killed whatever cancer cell was hiding somewhere else in the body that we could never see. And so that's what we do, all these things, and essentially we're hoping for the best, tipping the odds more and more in our favor. The third possible outcome is that the cancer came back anyway. And that's really disappointing for the patient, disappointing for their oncologist, disappointing for everybody because they did all this effort and it still came back. But again, that's going to be a small number of people after we've done all this. And then the fourth possible outcome is that I gave the example of dying of something else. If you had a heart attack and hopefully at an older age, the oncologist still considers that a win. You lived long enough and well enough to die of something else. And that sounds terrible, I know, but that's the truth of how we think, because this is how our minds work, is thinking in percentages. What is going to happen to this? If I have 100 women like this one in front of me today, how are they all going to do? If the majority are going to be cured already with surgery, do I have to be as aggressive with all those extra things? And so I should have said in the beginning to stop me and say, hey, Dr. K, any questions? Does this kind of make sense? I can give other examples if necessary, if anyone has any particular questions. I think, I guess the other thing I would say, let's talk more about, let's say, the older woman. Someone who comes in, now she has a 30% chance of dying of something else. The breast cancer has the same stage and everything else exactly the same. Now, the chance that she's cured with surgery is probably almost the same as, it's probably about the same as the younger woman. And so the chance that she is going to benefit from chemo is going to be and all those other things that we talked about, the hormonal therapy, the radiation treatment, all of those things, that difference is going to be small rather than being the difference between here and here. Also, in that difference of all the extra things we do after surgery that's going to improve her cure rate, we're talking about a smaller difference. Does that make sense? Because of the chance of that woman having other issues that are going to affect her overall prognosis. And so if the difference is small in terms of doing chemo, hormonal therapy, radiation treatment, then does it make sense to do all of those same things? Not so much. We would think about maybe doing the radiation treatment, since it's a local thing, just to the breast area, not to the whole body. We think about hormonal therapy because it's simple. It's a pill medicine, 1 pill a day, and taking it for a number of years, less side effects and than doing chemotherapy. And maybe we would try to get some of that benefit from doing less. But we wouldn't maybe put that woman through chemotherapy for only maybe a fraction of that benefit. Maybe we would just do the easy stuff and skip the hard stuff. And so that's how we would think about it in two different people with the exact same type of cancer. What else? Now, So some of the terminology we use is for this kind, I think I used the word definitive treatment when I was talking about surgery. So definitive treatment means that's the mainstay of treatment. There shouldn't be any replacing that. That should be the focus, is getting that tumor out. But again, those other things that we talk about, chemo, radiation, hormonal therapy, are all trying to improve the odds that we're cured. And so we call these extra things, we call that adjuvant treatment. Whenever we're talking about treatment, that's a word that we use a lot, but I don't know if most people know what it means exactly. And it means in addition to the surgery. The surgery is the main treatment. All these extra things that we're doing is trying to improve the odds that you're cured. And the challenge when a woman is sitting in my office after they've had their surgery is convincing them that they need it. Right? We know that they had their surgery. They feel cancer-free. For all intents and purposes, we hope they're cancer-free, but we don't know for sure. And adjuvant treatment means in addition to something extra above and beyond that surgery, and that's chemotherapy many times. That's radiation treatment. That's hormonal therapies, and we're we in the right situation, in a young woman who's healthy, who has an aggressive cancer, we want to be very aggressive. In an older woman who's very frail and has a lot of medical issues, we may not be as aggressive. And then there's everyone in between. There's young people that aren't very healthy. There's old people that are very healthy. And so everyone's situation is very different. And so we have to kind of figure out what's right for each person. Now, the other couple other things that we do nowadays is kind of deviating from that kind of schema for is something we call neoadjuvant treatment, and this is neoadjuvant treatment means treating treating women with breast cancer before they have surgery. And so it's a different example of let's say the same woman, 45 years old, who's come into my office and hadn't gotten a mammogram forever, but she started feeling a lump. And let's say she ignored it, unfortunately, and didn't want to go see the doctor, or maybe didn't have insurance or whatever. There's so many unfortunate reasons why these terrible things happen and get neglected and treatment gets delayed. But let's say she didn't have insurance, she didn't go see the doctor, and this thing was growing and it got big, and you started seeing the skin around the breast getting red and looking like an ulcer or whatnot, something bad. All right, and unfortunately we still see this even in this day and age where there's mammograms and all this technology is there. We still see folks not getting the screening they need. But this woman comes and she's got a large mass in her breast. It's like a tennis ball in there. And you can feel it, and it's coming through the skin. And under her arm, you can feel, lumps there that feel pretty hard. And she says these have been there for 6 months, but she hasn't done anything about it yet. And so she gets a biopsy, a needle biopsy of the lump. We're all pretty sure, we're looking at it, but we know it's cancer, but we have to biopsy it anyway to prove it and know what kind. We get all those different tests, and let's say we find that it's an aggressive type of breast cancer. It has none of the good markers, and it has only the bad markers. Let's say it's estrogen negative, it's progesterone negative, and it's HER2 positive. Let's say it's one of those bad cancers, and the surgeon looks at her and says, "Gosh, this thing looks huge. How am I going to get it out of there without having to get into her ribs or get into the skin, or I'll get all these lymph nodes out without leaving something behind?" And so the surgeon says, "I think you should go see the medical oncologist." That's me, and says, "This is going to be a hard surgery. It'd be great if we could do something to shrink all of this down before we do a big operation. And then it would give us a higher chance maybe of getting it out when we actually do the surgery." right? There's no point in doing a cancer surgery if we're leaving half the cancer there, or even 10% of the cancer there. That's just not good enough. We want to do a surgery for cancer when we think we can really get it all out. So when we think about neoadjuvant treatment, we're talking about treating a cancer before we cut it out. And we do this for some other cancers besides breast cancer too, but it's again most. But this is in the unfortunate. This is not the majority of breast cancer how we treat it, but this is what happens. We'll give specific chemotherapy or hormonal therapies to women with the right type of breast cancer before surgery, and for sometimes 3 months or 4 months or even up to 6 months to see it shrink down. And it's amazing a lot of times. We'll see these tumors melt. A woman will come back after 1 round of chemotherapy, and before she gets her 2nd round, she can already tell that it's shrinking. And first she's excited about it, she's happy about it, in the middle of all the side effects of chemotherapy, but nevertheless, the tumor is shrinking, and we get it knocked down to a point where it may sometimes get to the point where you can't even feel it anymore. And we're always happy about that. Just as a fine point, sometimes when that happens, it can be hard to find the cancer when we actually do the surgery. And so they do leave a little marker or clip there so that the surgeon knows where to cut it out. But we give chemotherapy beforehand, see this thing shrink down, lymph nodes shrink, oftentimes to the point of not being able to feel it anymore. And then the surgeon will go in and remove that area, or even the whole breast sometimes, and remove all the lymph nodes they can get out, and see how much cancer was left behind. And so that's a pre-surgery, pre-operative treatment, neoadjuvant treatment is what we do in that particular situation when surgery isn't really practical in the beginning. And we also think that if there's any cancer cells outside of the breast area and lymph node area that are there but we can't see them, we may be treating them earlier by treating them before surgery. And so that's another setting how we use treatment. We usually don't rely on radiation before surgery. Usually it's really mainly talking about chemotherapy. The other, maybe there's an exception in maybe older women sometimes with, and everybody's living longer and longer these days. So it's not uncommon where we see somebody with 90 years old who went for a mammogram. And sometimes we've wondered, how did they get, you go for a mammogram. You wonder at what age should we stop doing mammograms. But sometimes there's still 90-year-old women and men driving around and living pretty normal lives. And so a 90-year-old woman will get a mammogram and find a lump in the breast and find out that biopsy shows that it's cancer or whatnot. Sometimes, they'll say, I don't really want to go through surgery. There's risks of anesthesia and being put under, and you wonder if a 90-year-old woman's going to wake up if you put them down for a surgery. But because of risk, we think maybe do we have to operate on them? If it's a slow-growing kind of breast cancer and it's kind of small, sometimes we'll think about putting them on estrogen-blocking medication if it's that kind of friendly type of breast cancer that has an estrogen marker on it, and just give them a pill a day. That's not a common situation, but we do it because you can slow the cancer down. You can even make it shrink with just a pill a day and not have to put them through an operation. And so in that setting, we're using hormonal therapy neoadjuvantly, before surgery or in place of surgery, and just seeing. And oftentimes we can see the tumor shrinking on mammograms or just by examining the breast. We can get to the point where it's hard to even feel that lump anymore. And so that's another situation where we treat before surgery or in place of surgery with hormonal therapy when someone maybe isn't the best candidate for a surgery. And so the last perhaps setting that of kind of treatment that we think about for breast cancer is when the unfortunate has happened. A woman either showed up with breast cancer and it's already a stage 4 breast cancer. It's in the bones or liver or lungs or somewhere else in the body that even if we did a big operation on the breast and lymph nodes, we weren't going to get it all out because there's cancer somewhere else. Or someone went through all of those things that I described in the adjuvant setting. They had their mammogram, they had their biopsy, their surgery, and they did everything they were supposed to do. And they were one of those women at the end of the bar graph on that side where the cancer still came back. And it could have been 2 years later, or unfortunately sometimes with breast cancer, it could be even 10 years later, where sometimes the slowest growing types of breast cancer could sometimes show up years later, even, and just hiding out somewhere in the body. And unfortunately it happens. It's not common, but sometimes the friendlier type of breast cancers that we see can sometimes show up later. And when it does, it means it's a different stage of cancer. It's not a stage 1 or a stage 2 anymore. It'd be a stage 4 breast cancer at that point in time. And when that does happen, obviously we're disappointed and frustrated that everything we did didn't take, and the casino won. The doctor didn't pull off a miracle or whatnot. And so, in that gambling example, but in that situation, we call our treatments palliative, because we're not sure we can really cure that cancer anymore. It's spread beyond what surgery can cure, and we still have a lot of other treatment for it. It's not that all hope is gone or all hope is lost. There's still a lot of other treatment for it. Even in a stage 4 breast cancer situation, the prognosis is not, we're not talking about months. We're talking about years, and even trying to stretch it out to decades. All right, and so that's where all the newest things that we hear about, in the news, some new drug got approved for breast cancer. It's usually we're talking about in the stage 4 setting, where it's advanced cancer, and we're trying to slow it down, keep it under control, shrink it down, and help somebody live as long as they can with their cancer, and hopefully not from it, but hopefully live long enough to die of something else. But it doesn't sound very uplifting, does it? But we're talking about so many other types of treatments. We're talking about trying to keep it under control for years. And sometimes, oftentimes, even in a stage 4 breast cancer situation, we're not always talking about chemotherapy. Oftentimes, the same kind of hormonal therapies and pill medications that we think about working will work for a very long time. And even delaying the time when somebody might need chemotherapy or something like, or more aggressive treatments. And so in that situation, we have lots of things to offer somebody. And we try to keep the regimens as simple as possible and as easy as possible, and save the tougher things for way down the road. And so those things are usually, think about hormonal therapies, which are estrogen blocking medications. And those we use in women whose breast cancers had the estrogen markers and progesterone markers on it. We think about using, there's a new class of drugs that I think they still see them advertised on television, called like CDK4/6 inhibitors. I don't know if you see any of these names, Ibrance. I think that's been advertised on television lately. There's a whole class of drugs that are newer ones than Ibrance too, that are oral drugs that either in combination with hormonal therapy or by themselves can keep a breast cancer in check, even when it's a stage 4 cancer, even for a number of years. And there's a number of other chemotherapy drugs that we use in treating stage 4 breast cancer. The list of the possible drugs is pretty long, so I'm not going to try and make you memorize anything. But it's that whole section, talking about all the new drugs for breast cancer by itself, would be more than an hour lecture. And so I think I've been talking for a while now, haven't I? So let me just stop for a second or a minute or however long and take questions about things that I said, about anything else about breast cancer. We didn't really talk about a lot of things. We didn't really talk about genetics. We didn't really talk about immunotherapies or, there's all kinds of new things that are being studied in breast cancer that we didn't really address. I kind of wanted to give you an insight into how an oncologist thinks about breast cancer with that, with most women, we're talking about that bar graph. Again, we're talking about that, finding it early. What are we going to do about it? Is surgery enough? What else do we need to do? Chemo or radiation or hormonal therapy. What else do we need to do to try to make, the chances of that particular woman being cured as high as possible? And that's really where my job gets the most interesting, and trying to figure out what else is necessary. All right, any burning questions? Yes, ma'am.
They used to recommend 5 years for the.
Yeah.
And then I started hearing 10 years.
Yeah. So you think
Keep me up to date on that?
Right. So there's a bunch of international studies that looked at taking the hormonal therapy. Again, that's in the adjuvant setting we're talking about, where a woman's had a lump removed, lymph node sample, no cancer anywhere, but we want to improve that woman's odds of being cured. And we put them on a pill medicine. In the premenopausal women, it's usually, we're talking about tamoxifen. And in postmenopausal women, we're usually talking about 3 or 4 different drugs, Femara or Arimidex, or, there's a whole host of them. And so the one that was studied the most was really tamoxifen, and that's the one that was around the longest. But when they first did these studies, I think they tried 1 year. And then they did studies where the 3 years was better than 1 year. And then they did 5 years. And because in early stage breast cancer, or stage 1 or 2, when you're curing most of the people, and only a small percentage are recurring, and those recurrences are happening sometimes 5 or 8 years or sometimes longer after they were initially diagnosed, it takes a long time to do these studies. These studies would take 10, 15, 20 years to get the results. So even if they started it in 2000, we would only be getting the results about now. And so that's partly why these rules kind of change over time, is because new studies come out. But when these studies first were done, 5 years was kind of the gold standard. And then a study came out, I think it was called the Atlas trial. That trial was done all over the world, and they compared, put women in 2 groups, women who same stage, roughly the same, all stages of 1, 2, 3 of breast cancer. Stage 4 women who had breast cancer somewhere else in their body wouldn't be eligible for that kind of trial. But we were talking about looking at how many more people were cured by being on 10 years of tamoxifen versus 5 years of tamoxifen. And and then they even broke it down by stages. The women that were higher stage, like stage 3 breast cancer, who had at the time when they were diagnosed had more lymph nodes in their arm and larger tumors, their risk was higher. And so they benefited from being on the tamoxifen longer. The women with stage 1 breast cancer, there really wasn't that much difference between being on the tamoxifen for 5 years versus 10 years. And so I don't think that there's an absolute rule for everyone that says, okay, everybody should do it for 10 years now. It really is still individualized to that person's situation and that person's risk. If their risk is so low that then it may not, it's harder to prove that 10 years is better than 5 years. But if their risk is 30 or 40% of the cancer showing up again, then 10 years is probably better. And so I think it's got to be tailored to that particular situation and what some of the features of the cancer were in terms of determining what the risk is to begin with. And so, and it goes again back to that, if there isn't that much risk of there being a problem later on, there's less we have to do about it, or less we can do about it. The more we do probably isn't going to be helpful, and so I don't know if that's a long answer to your question, but it has to do with my take on all those studies that looked at 10 years versus 5 years is really that the women who had more risk to begin with need to be on the medicine longer. The women that didn't have that much risk but were taking the tamoxifen anyway don't need to really extend it beyond 5 years. There's some side effects to those medicines, and some of those side effects or risks of problems from those medicines went up, or chances of those, those side things were worse in people that were on it for 10 years. So for sake of, not wanting to increase people's odds of having more problems, we would probably back off on some people at 5 years still. They tried to do these same studies with the medicines that we use in postmenopausal women, like letrozole or Arimidex, or there's a whole host of those. And those have been sort of mixed. I don't think it's been that convincing with those medications that 10 years is that much better. We'd end up seeing more problems with getting osteoporosis of the bones and other kind of more menopausal type side effects in women taking those medications for longer. So it hasn't really panned out that for everybody 10 years is better than 5. It's still sort of a discussion. And some of my partners, some of my colleagues are kind of hedging the difference and saying, okay, we'll try for 2 more years and get to 7 and then call it. And any new study that we started 5 years ago would have to still wait another 5 or 10 years to get the results. So and the reason is because we have to wait that long to find out how long people, or when people are gonna, if they're gonna have their cancer come back, it's gonna take, that long to find out. Other studies where, we're looking at, let's say, a stage 4 breast cancer patient population, where we're looking at what the newest chemo drug is, where everyone has already been on 3 or 4 types of chemo, and you're trying to find out whether this new chemo is gonna be better than something else. You're not looking at 5 and 10-year outcomes. You're looking at, okay, how long did it take for the cancer to start growing again? And so you'd be able to figure that out in 6 or 12 months. You get a clinical trial done in 2 or 3 years if you enroll enough patients. But in this kind of situation about adjuvant treatment, you're trying to increase the odds that someone's cured when you're not even sure they need it, right? We hope everyone was in that first category in that bar graph where they're just cured with surgery. But we know that's not the case. We can't just hope. So we do other stuff, right? We're trying to do all that extra stuff to tip the odds in every woman's favor. And so that should have been enough time for somebody to think of another question.
Well, it's after 7, and Dr. Kannarkat has been really good. If you have any questions that you'd like to ask him afterwards, let's give him a hand for coming
I'll be
out
here.
tonight.